The following podcast is part of a certified educational activity titled Building Confidence in RSV Vaccination, Addressing Vaccine Hesitancy and Inequities in At-Risk Populations. Access the entire activity and complete the post-test at peerview.com/TTF860. Downloadable slides and practice aids are also available.
Good afternoon, everyone, and welcome to our session on building confidence in RSV vaccination, where we're going to address vaccine hesitancy and inequities in at-risk populations. I'm Jewel Mullen, here with
Jacinda Abdul-Mutakabbir, or Jam. Please feel free to call me Jam, like peanut butter and jam.
Right, or Jewel and Jam. Our goals for today are to equip you with strategies for identifying candidates for RSV vaccination, to augment your ability to administer appropriate and timely RSV vaccinations and associated information, and to provide guidance on culturally responsive educational strategies to address vaccination barriers. Did you bring any other goals?
No,
Okay.
No other goals.
Okay.
I think that completely encompasses it.
All right. So we'll start here. Respiratory syncytial virus in older adults. And I'm going to tell you now that while we are deliberately focusing a lot on the need to increase vaccination rates among older adults, given the FDA approvals and ACIP recommendations for the vaccination, we're going to insert some information as well, particularly related to pregnant women and infants. So, RSV, as you know, is one of the most common infections in childhood. From my reading, I see that it is the most common cause of hospitalization among children in the United States. It has clinical presentations that can range from asymptomatic to severe lower respiratory tract infections. Decades ago, when I was in medical school, we talked a lot about bronchiolitis without knowing a lot of what the etiology was. And now bronchiolitis is what we oftentimes hear about as RSV being the primary contributor for, with especially severe morbidity among infants less than 6 months, but also children less than 2 years or 5 years of age. In many people with mild RSV, it can remain undetected, but lower respiratory tract infections can contribute to pneumonia and exacerbations of chronic conditions such as asthma and COPD. The highest burden of RSV falls on children less than 5 and adults greater than 70 years of age. Among adults over 65, RSV is associated with an annual incidence of approximately 60 to 160,000 hospitalizations and 6,000 to 10,000 deaths. This weekend, I just took a peek at what's on the CDC website, looking at the burden of RSV among the population, adults and children, in the 2024 to 2025 season, and those numbers, the 60 to 160,000, are about double for that whole population, and as is the mortality. And so when I think about RSV in older adults, given what we know about RSV in children, I really think about considerations for RSV and lowering risk for severe infections as something that really warrants life course considerations. I might every now and then look at you and say, anything you want to add? Is that okay?
That is perfect, but I couldn't add any more than what you gave. Very important facts.
So here we show, over 5 years, monthly rates of RSV-associated hospitalizations in US adults 65 and older. And as we think about respiratory virus season, we see the trends here from October through the following September as, not surprisingly, showing the peak incidence or rates of RSV, hospitalization in the winter months, and trailing off. And for all of you in practice, we have recollections of which years in particular were, as my husband, who is now a retired pulmonary critical care physician, has described as the years when RSV was a particularly, and he told me I could say, he said this word, nasty disease. And for those of you who have cared for our patients in the hospital, I think you know just what we're talking about. The other thing that we know is that RSV infection and outcomes are influenced greatly by where people dwell. So we think about community-dwelling older adults in comparison to others. But before we even get there, I just want to talk about a study done in Rochester, New York, Monroe County, looking at residents in nursing homes and non-nursing homes and what the infections, hospitalization, and in-hospital death rates were, where we can see that there was an excess risk of infection, hospitalization, and deaths among those in nursing homes. Particularly important information that has influenced the approvals and then recommendations for RSV vaccination. And these are data from 2022 to 2023. Also from the Rochester area, Monroe County, Angela Branch and others have conducted a 3-year prospective study that looked at the population-based incidence of RSV-associated hospitalization in adults 65 or older, and stratified that by their living situation, looking at those living in communities, in assisted living, and skilled nursing facilities, with both assisted living and skilled nursing facilities being thought of that umbrella category of long-term care. And here we can also see the excess incidence of hospitalization among those living in assisted living and skilled nursing facilities. So as a physician who pivoted in the second half of her career to doing a lot more public health policy and administration, I've often had to answer the question, why is something a public health priority? And so, why is RSV vaccination a public health priority? Well, we just looked at some of the data around the burden, and once again, the reminder about, while we're talking about older adults even more so right now, the burden across young children and older adults. There are some other characteristics that make us really think about this as a public health priority. We know the populations who are at high risk and what that risk means in terms of morbidity and mortality. We also know that there is no effective treatment for the infection for those people. We also know that maternal vaccination greatly lowers the risk of RSV among newborns, particularly newborns in the first year of life, when that's the time that they are also most vulnerable if infected. So maternal vaccination at 32 to 36 weeks gestation does protect them, the newborns, and reduces lower respiratory tract infections by 57% among infants less than 3 months. And we have vaccines that have very high efficacy. And while we list here for you, because sometimes people remember brand names rather than generic names, in this non-commercial presentation, we see whether or not we are talking about RSV Pre-F3, which is an adjuvanted vaccine, also known as Arexvy, RSV Pre-F, also known as Abrisvo, and then the mRNA vaccine, RSV, the efficacy among among older adults 60 and over in reducing the risk of lower respiratory tract infections is very high. The other important reality for considering why this needs to be a public health priority and is that for everything that I just said and that we know, vaccination rates remain low. They have been increasing over the past few years since FDA approval of the vaccine and then modifications of the ACIP recommendations for who's eligible, but we still are in a situation where adults over 75, fewer than 50% of them have actually been vaccinated with RSV vaccine. So, how do we figure out beyond that group who's a candidate?
Thank you so much, Jewel. I really appreciate it. And honestly, irrespective of having seen these slides beforehand, I learned so much about why it is that we should address RSV and how it is that we need to move forward and why it's a public health emergency. I think that was such an important point that you brought forward. So here I'm going to
interrupt her for 1 minute because I'm just the doctor here. You notice this is the PharmD. This is the person who actually sometimes engages with people and patients around vaccination even more than we do as physicians sometimes these days when we consider where a lot of people get their vaccines. So we will continue to learn from each other. Thank you.
Absolutely.
Okay.
Thank you so much. So identifying candidates for RSV vaccination. So really looking at how we can address the risk, but also the inequities, which I think is such an important conversation for us to be having here at NMA. And I think also what Dr. Jewel brought up is also just so important when we think about just the percentage of minoritized physician and pharmacists that do exist. This is such a wonderful place for us to talk about the importance of collaboration, right? And how we can support each other in ensuring that we narrow these gaps. So let's go ahead and meet our first patient. So would this be a presentation if we didn't have some really great patient cases? So we have Miss A here. Miss A is a 66-year-old woman with asthma and COPD, here for a routine visit. She appears well, vital signs all within normal limits. During her visit, however, she mentions the occasional challenges in accessing care, mostly related to transportation, which have delayed her from receiving routine labs and then preventative care. She is unsure of whether she should go ahead and receive any vaccines today. So now here's where we come in, right? So then going back to patient A and what it is that we like to do, in a situation such as this, we would go back to those current recommendations because we would want to figure out, does patient A fit the profile of someone we would recommend that vaccine for? So current CDC recommendations, reinforcement of what Dr. Jewel said previously, are as follows. So we will go ahead and recommend that vaccine to any pregnant person within the realm of 32 to 36 weeks of gestation, so that being during September to January, when we think about just the transmission of infectious illnesses, especially those that are respiratory. In the Northern Hemisphere, it's around September to January that we see the most prevalence there. Also, all adults age 75 or older, so irrespective of the existence of risk factor, if you have a patient, they are 75 or older, we will make that recommendation for the vaccine. And then also individuals ages 50 to 74, if they have the risk factors that we will describe throughout the presentation, then we will go ahead and we will make that recommendation for that vaccine. So previously, we did have a recommendation for vaccines for those folks that were 60 or older. That was the initial recommendation that was made for the RSV vaccines. If you all remember, that was sometime in 2023 where it was shared clinical decision making. So basically, if you brought it up, you had a conversation, and then folks decided to get vaccinated. That was how we proceeded. However, ACIP did meet to change that, and this is the most updated guideline and recommendation made in June 2025 here. So I'm going to go ahead and hop into, well, what are those medical risk factors that we want to think about for those folks aged 50 through 74 when we consider who we want to make that recommendation for? So first and foremost, individuals that may have been diagnosed with a chronic lung illness, so that being COPD, some type of emphysema, asthma, so on and so forth. Folks with diabetes, and then folks that have diabetes with end organ damage. So we think about diabetic nephropathy, neuropathy, retinopathy, any cardiovascular diseases that come subsequently following that diabetes, severe obesity, chronic cardiovascular diseases, decreased immune function. So when we think about our patients that may have cancer or any other immunocompromising disease state, chronic kidney disease, I really want to turn our attention here. Please, please, please think about how chronic kidney disease can mediate that presentation or increase susceptibility to RSV. Folks that may have a neurological or neuromuscular disease, we want to think about that as a risk factor. Liver diseases, any type of hematological conditions, we talked about cancer or any immunocompromising disease states, we really want to consider that. Frailty, especially as we think about our folks 75 and up, frailty in the way that RSV presents can be a big risk factor. Residents in a nursing home, Dr. Jewell presented that nursing home data. We want to think about how that can increase individual susceptibility to the illness. And then other chronic medical conditions can be a risk factor, and folks can talk with their healthcare provider, but if they go to the pharmacy and they say, hey, I believe that I have a risk factor that's present, if they self-say that, if they bring that up themselves, then the pharmacy can offer them the vaccine. So there are many different ways that they can access that vaccine there, but we do want to bring up, these are the listed risk factors for consideration. So when we think about just those prevalence of risk factors, what we can note here is that we do see disparities, or we see differences in how those risk factors present when we think about folks that are 50 to 59 and then over the age of 60, and when we consider that or disaggregate by race and ethnicity. So we see an increase in those present risk factors for individuals that identify as Hispanic Latino, and then non-Hispanic Black, and then also not listed here, but what we can consider to likely be the case is our indigenous folks. So for our minoritized communities, we do see an increase in those prevalence of risk factors when we consider that and compare that to their non-Hispanic white counterparts. And then when we think about social vulnerability, we also see differences in terms of RSV presentation and hospitalization across the various vulnerability groups. So the CDC has what's called the Social Vulnerability Index. The Social Vulnerability Index considers 4 themes to quantify community level social determinants of health. So they use that SVI index to determine what are the inequities that we may see there. Is race, ethnicity a factor? Is transportation a factor? Is the housing conditions that folks live in a factor in terms of hospitalization or disease progression or disease presentation? So what we saw was that there was a higher incidence of RSV, whether that be a hospitalization or presentation of disease, amongst those individuals that resided in areas or a census tract that was concordant with a higher level of social vulnerability. So that means that folks that come from an area of high SES are more likely, or high SVI are more likely to present with RSV. And one thing that we can really think about is crowding, right? So if folks live in an area of higher social vulnerability, they're more likely to be exposed to crowding in their households, which can increase the transmission of disease. However, irrespective of the presence of risk factors, despite the disparities and inequities that we discussed, many adults are unsure about RSV vaccination. Only about 15.6% of those folks that are eligible to receive the RSV vaccine has received it. So that means that we are in a really poor place, or not the place that we'd like to be in terms of RSV vaccination. And we can see right there from that purple area, the folks that probably or definitely will not get the vaccine. So I would say, you all, we got some work to do, right, to encourage and figure out what are those barriers for vaccination, and we hope to do a little bit of that in this presentation here. But a no for now, or a no now, does not mean a no forever. So I want us to continue to think about that and to say that to ourselves. Just because there may be a no doesn't mean there isn't an opportunity for increased education that may promote eventual change.
Can I editorialize in your section?
Yes, by all means.
So sometimes where I work, people hear Black people vaccine hesitant, and then they don't even ask people or offer the vaccine. So some of you may remember during COVID how some people would say, patients, community members would say, I am not my social determinants of health. I have taken this habit of saying, don't label people as vaccine hesitant, vaccine refusal, and use that as a way not to make sure people are offered what they need. And don't use that as an opportunity not to have the appropriate conversations that people need to have when what they need to get a vaccine is the information. So there is a lot of opportunity on that slide that Dr. Jam just presented.
Absolutely, 100%. So we come back to Ms. A, 66-year-old woman with asthma and COPD, reason for visit, routine well woman exam. Once again, she appears well, vital signs all within the normal limit. During her visit, she mentions occasional challenges in accessing care, mostly related to transportation, and then having delayed labs and preventative care due to that limitation in transportation. And she's unsure of whether she would like to receive any vaccines. So, Dr. Jewell, I asked this question of you. Would Ms. A be a candidate for the RSV vaccine if she were to report to you in your practice?
Can I say something before I answer?
By all means.
Yeah, I just want to affirm everyone. Some of my colleagues in Texas and at Duke did a systematic review of provider behavior around vaccinations. It was published a few years ago. And one of the things that we surfaced, in addition to learning that most of what was written was really around HPV vaccine and how we engaged with patients and families, there's this other reality that part of what influenced provider behavior around vaccines, what they recommend to their patients and what they decide to get themselves, is really around the information that they have. And so looking at that pre and post test reinforced for me the simple but important benefit of just taking advantage of getting the right information at the right time. And as an internist, I'll tell you, every time I see a new recommendation, I say, how am I supposed to keep track of all this? So thank you for being here. But on the other hand, it's just so key because I think uncertainty makes it even harder to have the conversations that help guide people. So 66.
With
chronic lung disease.
Yep, chronic lung disease.
She is a candidate for RSV vaccine.
Absolutely, absolutely. So I agree with Dr. Jewell. If this were someone that I was interacting with, and my practice is in the community, so I actually pop up preventative care clinics throughout various areas in Southern California. And if this were someone that would talk to me or ask me about vaccination, or I would start the conversation with her and say, hey, have you heard of the RSV vaccine? This may be something, for you to consider. But I absolutely would, given the age, and then also the pre-existing disease diagnosis there. So non-communicable diseases, especially like asthma and COPD, can really predispose individuals to communicable illnesses. So we want to think about that relationship, and I would absolutely make that recommendation for her to receive the RSV vaccine. So I agree. I'm with you.
Sure, but the beauty of having this conversation with you is that she's also a candidate for the vaccine and for not getting it. Yep. Because of the other part of what
Absolutely.
You're talking about around her social challenges.
100%.
Right?
So when we have her present and she asks the question, if we know she may have an issue coming back to the clinic or coming back to wherever it is that she's having this interaction, then we want to make that recommendation and provide that vaccine right then and there, if she's willing to receive it, because we know that there may be the off chance that we don't get to see her again. So I'll go ahead and pass it to you, Dr. Jewell.
Empowering patients, championing RSV vaccination in vulnerable communities. Mr. B is 88, and he lives in a 55-plus community. He's got hypertension and BPH, both of which are controlled well with medication, and he's just come in for a blood pressure check. He appears well, has normal vital signs. And at check-in, the MA noted that he had not received his RSV vaccine. He wanted to know more about vaccination options and the risks and the benefits of vaccination. And as often is the case, his first point of contact wasn't his doc or mid-level, it was the MA. Vaccination is a team sport. So We talked about the indications and what vaccine eligibility is. So a little bit more about the vaccines themselves, which also helps us think about questions like which one should I get, which is sometimes what patients ask us, and whether or not one is so-called better or preferred to the other. So there are currently 3 FDA-approved products indicated for use in adults. I mentioned before the adjuvanted RSV pre-F3, the non-adjuvanted RSV pre-fusion, pre-F, and then the mRNA vaccine. The FDA, back in 2023, approved the adjuvanted pre-F for individuals who are greater than or equal to 60 or 50 to 59 and at risk of lower respiratory tract disease caused by RSV. A few months later, in 2023, they approved the pre-F vaccine for individuals who are pregnant at 30 to 36 weeks or individuals who are greater or equal to 18 years of age, up to, say, age 50, with chronic medical conditions that make them a setup for severe disease. And then in May 2024, they approved the mRNA vaccine for individuals 60 years old and over. The mRNA vaccine is still undergoing clinical trials, and one we're waiting to see the completion of should be done next month. But what we already know in terms of vaccine efficacy is that, as you can see here, compared to placebo, the mRNA vaccine has an 83.7% efficacy rate at reducing the risk of severe or lower respiratory tract infection from RSV. You're going to see on these slides references to RSV-associated disease with greater than or equal to 2 signs or symptoms, greater than or equal to 3 signs and systems, and in some studies, you might see lower respiratory tract infection rather than lower respiratory tract disease. I would tell you what the difference between those are, infection versus disease, or a specific composite of those symptoms, if there were one, but as of now, there is still not a single case definition. So the signs and symptoms for infection will include things that we know: cough, sputum, some shortness of breath, for example. For severe disease requiring hospitalization, those endpoints are generally looked at as hospitalization requiring increased oxygenation, mechanical ventilation, or positive airway pressure. So in general, when we look at what the efficacy is in reducing the incidence of these outcomes, it's a mix. There?
Absolutely.
And I think realistically, when it comes time to think about how this is manifest in patients, that's what's most relevant at this point until we have more information. And so I said all that leading up to the mix of terms that we see on this slide, comparing the RSV pre-F, the RSV pre-F3, in various studies where we can see the vaccine efficacy, once again, is, in general, well above 80% for reducing the risk of respiratory infection, lower respiratory infection, and then for RSV-associated hospitalization from a number of studies, once again, very high efficacy. So when it comes time then to thinking about these vaccines, if I had to say pre-F versus pre-F3 for older adults, I would say, which one do you have? And,
Absolutely.
And if
Put
I
it
had
in
to
the
call
arm.
you, I would say, which one do you have? Okay. The reminder, and this goes back to, we're mostly talking about older adults, but we don't want to forget about infants, which means we don't want to forget about pregnant women and vaccination, is that it is only the RSV pre-F, the non-adjuvanted vaccine, that is approved for use in pregnant women from 32 to 36 weeks gestation from September through January. But then the other question that oftentimes people will say is, yes, but I have heard that there are side effects, or am I going to be worse off if I get the vaccine? And so here's where we stand now in terms of people, how we address for ourselves and for people the understanding of what the risk of vaccination is. And the one that we still are paying, I would say, the most acute attention to, is that there has been a signal of a link, but not a causal link, between the pre-F vaccine, pre-F and pre-F3, and a slightly increased incidence of Guillain-Barré syndrome. Now, some people would say they don't care about the word slightly, they just don't want to hear about the incidence. But slightly increased incidence. And so this is still being studied, but at this point, there has not been any indication that there is a causal link between the two. And so here are the data related to that here. So here's what the Advisory Committee on Immunization Practices concluded about the GBS risk following RSV vaccination in adults over 65, as reported last October. A risk was observed. It was considered to be rare. And the risk of GBS wasn't any different between those people who got the vaccine alone or those who received them alongside other vaccines on the same day, which is something else that people wonder about, because sometimes we look at vaccination opportunities as the opportunity to give people more than one, especially during respiratory season. So the general conclusion, especially having looked at the burden of RSV and lower respiratory tract disease, is that the risk of developing severe RSV is much higher than the risk of developing the risk of GBS after vaccination. But, real world, I wanted to talk through this slowly because these are the kinds of things we think about when people ask us questions. And then even when we get to the next session where we talk through with people what their preferences are, I don't know if there's anybody else who has had patients that say, just tell me what to do, or who come back to see us at another time and say, well, you recommended this. So having the data is really important to also build not just our own confidence in having the conversation, but to help people really weigh their risks. Anything you want to say before you have a lot more to say?
No. It also, I believe, allows for an establishment of just a trusting relationship. I think sometimes with not to say negative, but with things like GBS, we can be afraid to bring it up because it may discourage vaccine uptake overall. So one approach that I've tried in my practice is I'm very honest about the clinical trials and the findings of those trials. But then I also go and, I talk about just how it is that the disease itself presents. And I think by me being honest and transparent, then that goes a longer way than had I not said that there was an association or something observed with something like GBS, in clinical trials. At the time that I began my education, it was myocarditis with COVID-19. So it was a conversation that, was harder to have because I was worried that folks wouldn't want to get vaccinated. And I work primarily with the Black community in California. But guess what? Because I brought that up, at least they had a good standing on what it is that was there. And they were able to go ahead and tell folks that would bring myocarditis up. They could give you the stats and the statistics and talk about what it is that they saw. And that went such a long way for the relationship that I have with the community members that I serve. So I leave you all, as Dr. Jewell wraps up this section on, honesty is the very best policy, irrespective of what it is that we as clinicians must be honest about.
Okay, so you said when you began your education, and it was myocarditis and COVID-19 vaccine. So when I began my education, and maybe it was swine flu vaccine? Anybody remember that? How many decades apart does that make us? It doesn't matter. We're in this conversation together. I think you were younger than that. But part of the other conversation then is we're talking about reduction of the risk of lower respiratory tract infection and continuing to remind people who might feel let down if they get sick that we're talking about lowering the risk of complications and not necessarily setting them up to think they won't get sick at all, but they won't get as sick as they might, which is really, really key. And so when getting back to, and now that I've outed myself as over 60, over 65, and over 70, I can also say I have the benefit also of being able to share with people what my own experience was, which doesn't mean they have to do what I did. But I think it's important to say, to be able to tell people, yeah, side effects, well, it hurts. You might have more pain in your arm the next day. You might have reactions similar to what people get when they are vaccinated against other viral infections, fatigue, fever, headachy, et cetera, that are usually mild. And to really think about those mild so-called adverse events against the risk of infection. To remind people again that especially in these past several months, reminding people that there will be ongoing research and surveillance, including what we can do in our own practices to track what happens to people so we have real life data from real people to help us guide our decisions on behalf of our community and they're not harmed by the wrong information. And then the importance of continuing to report adverse events through the Vaccine Adverse Event Reporting System and VSafe. RSV vaccination, when you think about it, timing it benefits people most given in the early fall. And adults who have already received a dose of RSV vaccine, at this point, it's not recommended to do a booster or a second dose. Other things to consider: it is acceptable, in accordance with the general best practice guidelines for immunization, to co-administer RSV vaccine with other adults. Co-administer, not mix, just co-administer. And this includes giving RSV vaccines simultaneously with seasonal flu vaccine, COVID-19, pneumococcal, Tdap, and recombinant zoster vaccines. Different arms or single arm.
All righty. So
back to Mr. B. How would you discuss RSV vaccine options with him?
So Dr. Jewell, if I were discussing vaccine options with Mr. B, I would bring forth all the information that you did. I think it's important to tell folks about the differences between the vaccines and to talk a bit about how the vaccines work. You can't make a decision if you don't have all the information made available to you. And then while he's there at the appointment, I would positively urge the uptake of the vaccine, but if he would want to come back and take it another time, I would make sure he knew that was an opportunity as well.
Thank you.
Yep.
I'll send them to you.
Absolutely.
All right.
So I'll jump right into our last section here. So strengthening health equity, building vaccine confidence within underserved populations. So now we have Ms. C. Ms. C is a 75-year-old woman coming here at a community health event near her home, hosted by a local healthcare system. She often has challenges getting transportation to medical visits, and the supervising physician engages a Spanish-speaking team member to facilitate the communication. Upon discussing the patient, it is discovered that the patient is unaware that she is eligible for the RSV vaccine. So when we think about just what are those barriers to vaccine decision making, so that awareness, right, that we talked about with Ms. C is something that readily exists. So you can't, ask for something or accept something or do something when you don't know that the opportunity exists for you. So in my community practice, I do a lot of education based on vaccine preventable diseases. And this year we'll be doing RSV education, but last year we did herpes zoster. And it blew my mind how many individuals had never received a recommendation about a relevant vaccine preventable disease. So my community is typically 65 and up. I asked them, have they received a recommendation to receive the herpes zoster vaccine, so not RSV this past year, and less than 50% had received a recommendation. Imagine if they had received a strong recommendation to receive that vaccine from a provider, whether they be a nurse practitioner or any other type of APP, a pharmacist, a physician, the difference that could make. And that can also influence acceptance. So that education that we talked about, providing information about the vaccines and the disease itself, well, that can increase uptake or acceptance about the vaccine, because now folks have information at their disposal, but more importantly, they have awareness of both the disease, benefits of vaccination, and availability of such. So disease-related education, if you don't know about the risk, if you don't know that certain risk factors exist and that can increase your opportunity or susceptibility to infection, you don't really think about the importance of being vaccinated against that particular preventable disease. So we really have to go ahead, not only recommend, but educate, not only about the availability of the preventable options, so the vaccines, but the disease itself and the risk factors associated with them. And then insurance coverage and costs. So when I talk to my community, using herpes zoster as that example about, the herpes zoster vaccine, we have a question in there that asks about costs. And I cannot tell you the number of people that had no idea that the vaccine was covered through Medicare Part D. So we have to make sure that we are educating, especially those folks 65 and up, about the availability of the vaccines and the cost of the vaccines and how it may be subsidized through various avenues. So when we think about education, well, first we need to make sure we're offering disease and vaccine related information, and then we can encourage, right? So we can provide that strong recommendation. We can determine whether co-administration is possible. So if you have someone there and you bring up the influenza vaccine, if they are a candidate for the RSV vaccine, then we can go ahead and make sure that we bring that forth to them and tell them, hey, you can get these at the same time. And then we can also offer incentives for updated vaccines. I actually partnered with a community organization. They gave a $50 gift card if folks received the flu and COVID vaccine as co-administrated vaccine. So we had a great showing at that clinic, for folks that wanted to participate. And then we think about just what are those really important things that we want to make sure that we hit for older adults about RSV vaccine. So those 4 main talking points, we want to talk about the complications. So as we age, immunosenescence occurs, and folks that are at older age can be more susceptible to those RSV related complications. And we see worse outcomes when compared to influenza. So that's important to bring forward. Vaccine availability. Hey, these vaccines are available for those 50 through 74 with those risk factors we described, or 70 in everyone 75 and older, and then those folks with immunocompromising disease states. We want to make sure we bring that forward, especially if we engage with folks with those particular risk factors. And then we want to talk about the fact that there is no available treatment. So prevention is our best policy. That's something something I always talk about with my community. I tell them like, hey, we do have treatments, but I'm not, you know, you don't want to be at the disposal of maybe this treatment may work and maybe it won't. You want to be able to prevent the disease and the severity in which it presents, you know, at the start of that. And then eligibility. So we really want to make sure that we talk to the patients about the availability, what is that criteria for vaccination. But once again, I want to just continue to reinforce the importance of us, especially as minoritized clinicians that provide education and advisement. Healthcare provider recommendations, especially if this is someone that folks trust, can just go such a long way. So remember to really make sure that we recommend those vaccines for folks who fit the criteria. And then educating about the risks versus the benefits. So this goes back to the discussion point that Dr. Jewell engaged me on, right? So we want to make sure that we are bringing forth just the benefits of vaccination, because GBS will be a conversation we have to have. So we want to say, hey, vaccination can decrease your risk of hospitalization by 75%. That is great. You know, you have a very small risk for GBS, you know, that exists. But guess what? That benefit still supersedes that very minimal risk. So, and on top of that, we have to think about just the deaths that it may prevent. And then I always make sure to describe the disparities in the deaths that we see across individuals that are racially and ethnically minoritized and those that reside in areas of high poverty. So it's always worth having that conversation of the benefits far outweigh the risks that exist. And then we have this wonderful framework provided to us from AHRQ about how it is that we engage or encourage folks to receive vaccines. So first, we can seek or we can initiate that conversation. We can start that conversation with individuals. We can help. So that means that we can provide clear, understandable information about what it is about the vaccines, about the viruses. We can assess the patient's values, the preferences, the situation that may exist. We can reach, so we can think about, you know, what are those things that we can do to engage this person. Is providing, you know, materials. Maybe I'm not the one that has the conversation. Maybe the conversation with the pharmacy technician or the MA is a conversation that may allow for a better uptake of being vaccinated. You know, we can support each other and collaborate in those efforts. And then when we think about, you know, evaluate, we want to make sure that we regularly review and so on. So when we think about just how it is that we provide these vaccines, well, when we think about just collaboration and who are those folks, well, let's think about, you know, maybe collaborating with pharmacists, whether surrounding or so on. So pharmacists and pharmacy staff play a major role in vaccination, and we can see that listed here with those vaccines. And then we can improve our communication strategies, so it never hurts to get information from more than one source. So when we think about strategies to address vaccine inequities, so we want to identify individual factors that may increase susceptibility to vaccine hesitancy. We want to apply principles of active listening. I like to do yes and, to where, you know, I listen to what it is that patients tell me, and then I say and provide additional information. So I acknowledge them, acknowledge their beliefs, and provide an opportunity to give the facts. We engage trusted community leaders or faith workers, and then we can help patients really see the affordable access that is available for the vaccines. So this is an example of the tiered process that I use in my practice to provide vaccines, and I won't spend a ton of time here. You can go to the reference below if you would like more information, but it really is a community-based approach to where I engage faith leaders. I collaborate with 4 churches from September to December to provide education alongside actual vaccines. So we have various tiers that exist in that process. And then these are the outcomes, and this was from our COVID-19 intervention that has now progressed, and we've addressed influenza, herpes zoster, and this year we'll be talking about RSV. But what we saw was, following education that I provided alongside the faith leaders as my chaperones into the community, we did see an increase in the number of Black individuals that were vaccinated within the community. So previously at the large vaccination site, we had only vaccinated about 3% of individuals that identified as Black, but they represented 20% of hospitalizations. Well, when we did this clinic following those tiers, we were able to vaccinate 83.5% of individuals, that were vaccinated there identified as Black. So a necessary overrepresentation of a group that had disparities. So this is just an example.
I should say I would be happy to pass over what Austin Black Physicians Association has done to answer some questions if you want.
Yes, so I just want to
okay, I'd be
end
happy
with
right.
that tier 3 is really that important tier for us to consider. How do we engage other clinicians in that conversation? And here is the Austin Black Physician Association, so we can see that these efforts exist in multiple capacities, but more importantly, the importance of individuals that identify as racially and ethnically minoritized and the gaps that we can narrow in minoritized communities. So let those 2 examples serve as a basis. So with that being said, this is patient C. So if I were to talk about how I would engage in counseling, I would make sure that we continue to engage that Spanish-speaking person, right? And I would make sure that the information was translated in a way in which patient C could readily receive it, but I would provide the necessary materials to make that decision. So we will go ahead, and this is the summary of the conversation topics that we covered. So you all can go ahead and read this, but please also send in your questions. So as I read these summary points, we can launch right into the question and answer portion. So RSV poses a serious health risk to our older adults. CDC recommends all folks 75 and up, and then 50 to 74 for those people with risk factors. Vaccine efficacy is high, about 80% or so for all 3 of those vaccines. Health equity remains a critical focus. However, through community engagement and partnering with local entities, we can increase acceptance there. So we will go ahead and take all of the questions that you all have here. I think we have a few that have come through. So Dr. Jewell, I'll pass it to you to go ahead and start with the questions.
So we'll do a little lightning round response and hope that we might even touch on a more expanded answer during the webinar and next week. 2 weeks. Can't wait for it. So one question that we received is whether or not there's an immunology lab titer that we can perform post-vaccinations, such as we do with Hep B. I'm not aware of any such thing in clinical practice, but I also know that as we've thought about that, I remember during COVID, people said, "Oh, I went and I got some titers." We can't necessarily correlate what those results are with the actual immunoprotection that an individual has anyway. But I'm not aware. Doesn't mean it doesn't exist, but I'm not aware of any. Another question was whether or not there are data about a potential link between GBS and RSV, specifically in the Black community. I have not seen any such data. I think it would also be really hard to know what to do with such data, given how small the numbers are. I joked before we started that I didn't bring a soapbox, but I just made one. So here's my soapbox other response to that. If somebody came to my office and said, "I heard there is such a link," I would look really hard and also want to see what that source was, given the world of mis and disinformation that we live in right now and how much more the Black and other minority communities are being flooded with it. Another question. Okay with you?
Yeah.
You want to do the next one?
I can go ahead and take the next few. So are most of the pharmacies providing immunizations? Yes, they are. So the RSV vaccine is available. I'm actually in my practice partnering with community pharmacies in the community to provide the RSV vaccines, because I myself am unable to carry them, but they can. So the pharmacies do have them, and I agree, pharmacy consultation should be something that's offered. So if you and your practice aren't able to do it, feel free to direct them to a community pharmacy or independent pharmacy, and they should be able to receive them there. So we have another question that states, I manage patients with heart failure. Besides, at the height of COVID, I did not typically bring up vaccinations with my patients. I believe they should be vaccinated, but leave that to their PCP, as I am focused on other things during the appointment. Absolutely understandable. Through this conversation, I realized as a specialist, I need to play a more active role in discussing vaccines. What do you tell patients that qualify for all 3, but do not want all 3 just due to vaccine fatigue? This is a phenomenal question. Thank you to whoever posted. I think at present, everybody, wherever we can have vaccine conversations, that's likely the most important thing that we should be doing. And for me, I really take it from a matter of what vaccine season we're in. So if someone talks to me like in the summer months and they are someone that presents with a high risk for communicable vaccine preventable illnesses, then I'll talk about, the vaccines they can get at any time. So like zoster or shingles, I'll say, okay, you can get that vaccine at any time. And technically they can get the RSV vaccine at any time. We do broadcast it during the fall months because that's when we see just an increase in respiratory viral illnesses, but they could get it at any point that they would want to. They could get the RSV vaccine then. So influenza, so I really broadcast the respiratory illnesses, so influenza, COVID, and RSV. I broadcast that simultaneously, and I make sure to tell them that because they're inactivated vaccines, they can get them at the same time. But I really leave it up to them. I tell them the risk associated, what I believe the pain may be, if they get the vaccines. I tell them pain is different for everyone, but it's up to them. But I think, that's kind of how I go about the conversation. So thank you all. It was such a pleasure to engage.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This educational activity is supported by an independent medical education grant from GSK. To access all materials for this activity, visit peerview.com/TTF860.